So it's in Facebook, and I've already let in the participants. You can begin whenever you feel it's okay.
Yeah, we wait some time. There are now.
Caputo, you are the.
Hi, Mati.
Caputo, okay, you are there.
Yeah, I'm there. I had to change machines.
Okay,
Nice
okay.
to see you guys.
Okay,
Excellent.
so open your video. Yeah, very good, very good. Nice to see you. Nice to see you.
Nice to see you too.
Yes.
Let me transfer my talk to the other machine. So who's talking now?
No, sir. Just a minute. Now we will start. You will see the things how it goes. Yes. Just a minute. Yeah.
Okay. How's the situation in Baroda with the epidemic?
Yeah, it's okay right now. Yeah, everything is okay right now. Yeah.
Okay, let me shift my talk to the other machine.
Okay, so Arun, can we start now? Okay.
Yeah, you may.
Yeah. Okay. Very good. Yes. Okay. So. And Arun, everybody is in, no? So now in all the case.
Yeah, you may start now.
Okay, very good. Yes. Okay.
It's in Facebook also. It's on Facebook.
Okay. 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 So Mati, can we start now? Yes.
Yes, please.
Will Skilder, can I start? Yes. Okay. Okay. Very good. Yes, sir. Maria. Huh?
Hello and welcome to the second day of the two-day international webinar on focusing on mathematical models and analysis of COVID-19 crisis. Hello and welcome to the second day of the two-day international webinar.
Keep other devices in mute. Keep other devices in mute. For Ganesh sir, keep other devices in mute. Otherwise, it will pick up echo.
Hello and welcome to the second day of the two-day international webinar on focusing on mathematical models and analysis of COVID-19 crisis, jointly organized by Office of International Affairs, the Maharaja Sayajirao University of Baroda, and Lappi Pranta University of Technology, Finland, in collaboration with Department of Mathematics and Statistics, Faculty of Science and Department of Applied Mathematics, Faculty of Technology and Engineering, the Maharaja Sayajirao University of Baroda. I, Maria Jessica Sharma, Assistant Professor, Faculty of Social Work, the Maharaja Sayajirao University of Baroda, am given an extremely delightful task of introducing an extremely versatile and dynamic person, our Honorable Vice Chancellor, Professor Dr. Parimal Vyas. Professor Dr. Parimal Vyas is the Vice Chancellor of the Maharaja Sayajirao University. He is a dual professor of management studies at the Faculty of Management Studies and also professor of commerce and business management at the Faculty of Commerce, the Maharaja Sayajirao University of Baroda. He has served as former Dean, Faculty of Commerce, and former Head, Department of Commerce and Business Management, Faculty of Commerce, the Maharaja Sayajirao University of Baroda. He has over 35 years of postgraduate teaching and research experience and has undertaken 5 major research projects sponsored by the University Grants Commission. He has published 10 international, 61 national research papers, and 8
You're muted.
webinars, and also acted as resource person, expert speaker, panel member in such academic events. He is a member of Research Development Committee in various universities within and outside the state of Gujarat. He has been honored as an expert subject member in Board of Studies in various universities. He has acted as an expert member, the Vice Chancellor's nominee in various selection committees in various universities. He has been appointed as an external referee for the evaluation of PhD theses in various universities within and outside the state of Gujarat. He has contributed as seminar director and also course director in the international, national, and state level conferences organized by the Sardar Patel University, Vallabh Vidyanagar, and the Maharaja Sayajirao University of Baroda, Vadodara. Sir has proved to be an exceptional leader, especially during the pandemic, as he has always encouraged us to remain connected to our students through virtual media. The Maharaja Sayajirao University of Baroda, under the able guidance of Professor Parimal Vyas, has undertaken numerous webinars on various subjects over the last 3 months, because Sir truly believes and lives by the philosophy that learning never stops. With this encouragement by our side, I request the moderator for today, Professor Jean-Guy Caputo, to kindly take over and begin with the webinar session for today. I hope each one of you have an enriching learning experience. Thank you.
So, thank you very much for this introduction. It is a pleasure to introduce the next speaker of the webinar. The next speaker will be Uffe Thygesen from DTU Denmark. So Uffe is a professor of physics in DTU, and he will tell you more about what he has done to model the epidemic. Please, Professor Thygesen, you have 25 minutes.
Thank you very much, and thank you for the kind invitation to join this event. I've been looking forward to this. I certainly enjoyed the talks yesterday. Here, let me share my screen. There. Can you just confirm that you can see my title slide now?
Not yet.
Oh,
not yet.
Okay. I'll try again. How does that work?
Now, yes.
Yeah, okay. Thank you very much. Okay. So, yes, so I'm here to tell you briefly an overview about the COVID-19 epidemic in Denmark and the modeling efforts that we have pursued to describe this epidemic. The reason, the background for my participation here is that I work at the Technical University of Denmark, at the Department for Applied Mathematics and Computer Science. But then I have also participated in an expert group which was formed in the early phase of the epidemic by the health authorities to provide advice to the authorities on the modeling of the epidemic. And what I will share with you is essentially a status report of what we have been doing and what the current situation is and where we think we're heading in this from the point of view of advice to the authorities. First, I should give you a brief overview of the status of the epidemic itself in Denmark. This graph here shows the daily hospitalizations, so new admissions to the hospitals in Denmark. The numbers are fairly low. That's because Denmark is a small country. What we see here was an initial surge that came quite rapidly and suddenly, and it was triggered by Danes who went abroad on winter vacation and brought the disease back to Denmark. And that caused a lockdown, quite rapid response by the authorities, a lockdown on the 11th or 12th of March. Which means that the exponential growth phase was never pronounced and clear in Denmark. The data sort of matches 23% per day growth, which agrees ballpark with what we have seen in most European countries, give or take. But the exponential growth phase was, as I said, not pronounced and not very clear in a Danish context. After the lockdown, the daily hospitalizations continued to increase for yet another 13 days, which is in agreement with our understanding that it takes about 2 weeks from the time you are infected until you get admitted to the hospital. So this peak here in the daily hospitalizations agree with a peak in new infections occurring at the time of the lockdown. But of course, we don't monitor the new infections. After that, at the time of the lockdown, Denmark, as every other country in the world, probably was talking about flattening the curve. And the objective of the lockdown was to flatten the curve. But that was not at all what happened. We more or less, that was introduced a sharp kink in the curve, so it was kinked and not flattened. And we can say that the lockdown was surprisingly effective. We had thought that the lockdown would just slow the spread of the disease, but actually it went to an exponential decay phase. Since that, the government has reopened the society with a number of on a number of occasions. I won't tire you with the details of when schools were reopened, when restaurants were reopened, etc., etc. There have been a number of steps here, and we are actually surprised that none of these reopenings have led to a second wave. We see that the numbers are still declining in Denmark, although the from the point of view of regulation, government regulation, there are very few measures in place. We still have border restrictions. We still have nightclubs and discos are still closed. Large gatherings now with more than 500 people are still, public gatherings with more than 500 people are prohibited, except for political demonstrations. But apart from that, life is, from a legislative point of view, life is fairly much back to normal. We can see that the behavior of people is not back to normal, but in terms of legislation, most of the drastic measures have been lifted, and still the numbers continue to decline, which is a partial surprise to us, but a positive surprise. As I said, I have been participating in this expert group here that provides advice to the health authorities and the government. Our main task has been to predict the effect of reopenings. We have employed a number of mathematical models. In this talk, I will not go in too much detail with these mathematical models. I'll rather give you an overview of our aims and objectives. But briefly, the main workhorse, which I will talk slightly about here, has been an ODE model of SIR type, so classical stuff. We have pursued individual-based models. We have done some time series analysis for estimation and prediction. We have done a rather careful study of flows of patients through hospitals of a survival analysis type. And then there have been various bits and pieces, statistical models and process studies to support this here. The workhorse, some of you have seen this slide before here, but nevertheless, the workhorse is an ODE model, which is essentially of SIR type, but as you can see for the diagram here, expanded with a number of additional states. And this here diagram represents a simplification on two accounts. First, we have worked, most of the time we are working with two age groups, younger, defined as below 60, and older as defined above 60. And that's not visible in this graph, but we do have two of these graphs interacting with each other. And then actually each of these states, in particular the exposed state, is subdivided into three states in order to match empirical data on residence times. If this here was a single state, then you would have exponential residence times, but the data suggests gamma distributed residence times. And therefore we have three internal states to represent that particular exposed state, and similar for the infected states. The main task has in providing advice to the government on this here has been to establish the contact structures. And by that I mean how many times do people in different age groups interact with people in other age groups, such that this may lead to a transfer of the disease. And that has been a very time-consuming and nitpicking job of predicting when we reopen schools, how many additional contacts does that imply between children in their age group, between children and students and their teachers, etc., etc. That has been a tremendously time-consuming job to do these predictions. Not sophisticated mathematics at all, but very important and, as I said, time-consuming. We base this on a British study because there's no data available from Denmark. So our models have been based on these two British, these two studies, which are in a British context, and then we have
I would suggest 3 hours.
Sorry, some noise on the microphone. Am I the only one?
They would have to speak for the
Okay, well, I'll just try to continue. A key thing we are focused on two phenomena. The one is the spread of the disease in the society, which was given by this SEIR model with two states, and then another which is the course of patients through hospitals. And this component has been key because the objective of the entire modeling effort has to be to predict the load on the healthcare system. And therefore, we have this statistical model which estimates, for example, for patients under 60 years, with 6 days after hospitalization, how many of these patients are discharged, how many are in general wards, and how many are in ICUs. This here is estimated non-parametrically and then fed in as convolution kernels, where we can then convolve the hospitalizations with these transfer functions to get the hospital loads. It's interesting to see how well we compared here. So this is the early results from our first report, which was published on April 2nd. So used basic data up to around late March, where we predicted that after the lockdown, we predicted that the curve would just be flattened. But as I said, the curve was not flattened, it was kicked. And that simply means that we interpret this as social distancing was more effective than we had predicted. That means that we, in ballpark numbers, we got the hospitalizations, we overestimated them with, so that the actual data was only 2/3 of the predictions. I think that's, we're not ashamed of that, given the amount of data that was available at that time. I think that is a reasonable fit, but I'll leave for you yourself to judge on that. That was what it gave. Since that, the following up has been to predict the consequences of various reopening scenarios. And this is from one report that we submitted to the government. There were dozens of these graphs here, so I'll just show you one of this because it's for the Danish authorities. The text is in Danish. Apologize for that here, but it has a base scenario, in this case here, of what would happen after early May if with no relaxations, and then with one scenario for relaxing or reopening reopening the society. In this case, it has focus on schools and restaurants. So this here if schools and restaurants remain closed, and this here if schools and restaurants were opened. And these predictions here were then used by the authorities to take in the political discussion between the government and the parliament on how to reopen society. It turned out that a major political debate in Denmark concerned the reproductive number, and that came as a surprise to us. We thought the reproductive number was something for the specialists deep in the engine room, but all of a sudden it was a political concern because the question was, how serious was the epidemic in Denmark and how effective were the measures in place? So here's an attempt that I did to reconstruct the reproductive number. It's based on a statistical model where I have a prior assumption that the reproductive number is a random walk. I introduced daily new infections as latent variables. They satisfy a stochastic recursion, which is parameterized by the reproductive number. I assume that the time between primary and secondary infections is known from clinical studies, as is the time from hospitalizations, from infections to hospitalizations. And based on that, this here is then the Bayesian posterior, or the smoothing estimate of the reproductive number. And what we can see is a decline before the lockdown, but happening in the days before and after the lockdown, which essentially took the reproductive number from more than 2.5 and down to below 1 in a matter of very few days. And since then, the reproductive number has been largely constant despite reopening scenarios, which is a surprise, but there it is. We found that the reproductive number is leads to some confusion. So I'm actually personally a little bit annoyed with the reproductive number in the debate, because what we can observe robustly are exponential growth rates, daily growth rates. And when we try to compute the reproductive number from these growth rates, then it depends on model structure as well as assumptions about the serial interval. And that means that when we compare different studies that publish different reproductive numbers, it is difficult to, at first glance, it is difficult to distinguish what is the actual difference in the dynamics of the epidemic and what hinges on different assumptions of models and serial intervals. To illustrate that, here I have a graph where I show daily growth rates ranging from -10% per day to +25% per day. That's roughly the range that we have seen in Denmark. And then different values for the reproductive number based on SIR model, SEIR model, with different assumptions of the serial interval, either 5 days or 7 days. In the early phase, we thought that we had roughly 7 days serial interval. Now we believe we have roughly 5 days serial interval. And as we can see, when the growth rates are high, as they were in the early phase of the epidemic, then these different model assumptions leads to quite pronounced difference in the reproductive number. And this is not a difference in the actual dynamics of the disease. It is just difference in model assumptions about how, in particular, the distribution of the time between primary and secondary infections. And that tends to mud the debate. So comparisons of the reproductive numbers between studies should be done carefully. Our big question now is what happened to the epidemic? We haven't seen the second wave yet. We have seen local outbreaks, and they are controlled locally now by local measures. And this isn't despite of the fact that in Denmark, we are very far from herd immunity. We have roughly 2% seroconversions. As I said, the restrictions that are in place now are mostly concern large groups and large events. And that leads to the hypothesis, two hypotheses for why are we not seeing a second wave. And the one says that the super spreaders and super spreading events are critically important. And the other says that public awareness and compliance remains high, even if there is no very few government measures to control the epidemic still in place. And these are two competing hypotheses for why we are not seeing a second wave yet. We know that at this point here in Denmark, the structure of the epidemic is given to a high degree by differences in socioeconomics and subcultures and singular events. And to see that here on the left figure here, I have the cumulative incidence per 100,000 inhabitants over the entire country of Denmark. And we can see there is a fairly sharp incidence in these western regions. This is west of the capital of Copenhagen. And this is, should we say, blue-collar neighborhoods. Whereas the white-collar neighborhoods where people can stay at home from work and work over Zoom, as we are doing right now, these neighborhoods tend to have less incidence. So there's a coupling between socio-economics and dynamics of the disease definitely happening now that has to do with work situations, and it has to do with how close people live together. Then when we go over the last 7 days here, we see that there is a very localized outbreak in this rural, quite remote region of Denmark and northern Jutland here. And this has been linked, which is sort of the black swan now, this has been linked to an outbreak on mink farms. Mink farms here. So, we are not particularly concerned about this, but we believe that there is taking place infections in mink farms and also between mink and humans. This is not a major concern, but something that we have to be aware of. In this particular case here, it has led to the culling of the mink in these farms here, but no panic regarding that yet. As I said, one hypothesis for why there is no second wave yet is that compliance is still high. To examine that, there's a project called the HOPE project, which monitors the public sentiment. And this left graph here shows the compliance. There are 3 measures. The red one here is how large a group of the population wash their hands more than 10 times per day. I can personally tell you that washing hands 10 times per day, that's quite a lot. Myself, I'm embarrassed to say that I, not on every day, I reach 10 times hand washing per day. But anyway, we can see that fairly large group in the population tend to avoid crowds. A crowd here is defined as more than 10 people. And to avoid crowds to a higher degree than they did before the epidemic. So people still avoid crowds, even if these crowds are not illegal. The top line here is simply a question: do you think in general that your behavior is changed relative to the before the epidemic? And we can see that something like 95% of the population have changed their behavior. It doesn't say how much or how drastically or what is the effect, but we can certainly see that people have changed their behavior voluntarily. This here does not include legislation, but voluntary changes in behavior. And that may be an important reason why the epidemic is still under control. We see some decline in these numbers, so people are beginning to relax, and we feel that may lead to a second wave. These people also, this project is also monitoring the optimism and the fear. And we can see that the blue curve here is the fear among Danish citizens for the epidemic. We can see that in March, there was 85% were personally fearful of this epidemic, but that number is declining now. And the general sentiment in the public is that the situation will be under control. In particular, the optimism is also increasing, that the very large share of the population now believe that the authorities will be able to get the country through this crisis. So I think in the interest of time, I will skip that slide here, and maybe also this here. This here was, I'll go through this rather quickly here. It was an attempt to discuss the role of superspreading and heterogeneity in contact rates. It is well known in the epidemiological literature, so this is not new, but just a well-known fact, that if there is heterogeneity in the population, that will lead to smaller overall attack rates than what an homogeneous, well-mixed population predicts. This is a well-established fact, and this here just shows that with high degrees of heterogeneity, so off the diagonal, we can have attack rates which are much smaller than the well-mixed assumption leads to. And it's not clear to which degree our society is heterogeneous, but it is certainly an effect that we believe is important. I think my time is up, so I will jump to conclusion now. In March and April, there was a sentiment of impending doom in Denmark, and now the sentiment is that this was diverted or at least postponed. We're all holding our breath, preparing for a second wave, both in the general public and also in the health authorities. And that means that now we are confident that it is possible to control this epidemic, and that means that the discussion is now about which measures are most effective and what are proportional mitigations. In that, it seems that voluntary social distancing is more effective than we have thought. So the question now is how to maintain voluntary social distancing without harming the economy too much. We have a hunch that super spreading appears to be central, so it will probably be a while before we are reopening festivals and etc. There is an increased awareness that this disease spreads and hits unevenly. We have all known for a long time about the difference in age structure, and we're also becoming increasingly aware of how social structure determines where the disease hits. In the case that some professions are hit harder than others, in particular the less fortunate citizens are hit harder because they have to be out there and make a living despite the presence of the epidemic. And these differences in age structure and social structure between which determine the dynamics of the disease, means that all recommendations must be country specific, so adapted to the age structure and social structure of the specific country. So that means that while I think it's of paramount importance that we exchange experiences and views between countries, we must be aware that what is right for one country is probably not right for the other country. And with that, I conclude my talk and thank you for your attention.
Thank you, Uffe, if I may. It was a very interesting talk. We have a little time for questions. So Professor Kruger wanted to ask a technical question. So go ahead, to.
Okay, I just have a technical question and a comment. The technical question is just the contact matrix which you showed at the beginning of your thing. Is this from this polymod panel in data survey, or have you your own? Okay, so it's from the polymod.
No, that's what it is, yes.
Okay, fine. The second, I mean, just a comment on this super spreading and tail. I very much agree with what you said, that if you have individual heterogeneity in the reproduction number, what you see, of course, in the outcome, and I mean in the number of cases, is the mean effect. But if the distribution is heavy-tailed, then cutting the tail actually really reduces the mean very much, and that is precisely why having a lot of things still open, but just the heavy-tailed stuff closed, can really effectively reduce the things. And it would be nice actually to, I mean, if you add a continuous, it's not really just two groups. I mean, it's a little bit of continuum. And if you add it even in an ODE, you get a partial differential equation. And it would be nice, we do it on the micro simulation model, but it would be also nice to study maybe extended partial differential equations having into account heterogeneity.
Maybe.
Yes, I think I totally agree, and I would actually love to do a specific talk on that particular subject.
Right.
So maybe we can follow up on that.
We have monitored.
Maybe.
Can I just make one that takes me 30 seconds?
Okay, go ahead, Phil.
We have monitored here in Poland these little outbreaks because we don't have decline, and we see very much that it's driven by these larger events above 10, 15 cases. And we also estimated the serial number from the patient data, and it's between 5 and 6 in our cases. So very much in agreement with what you said.
Okay, thank you. I have one comment. You say it's surprisingly effective, the lockdown. When you look at data from other countries, you see that immediately or very quickly after the lockdown measures, the growth rate of the confirmed cases has a kink, you know. Yes. So it's not. I'm not surprised that the lockdown is effective.
No, I agree. What I'm saying is not that I'm not saying that Denmark is a singular case here. I think we're seeing the same in a large number of countries. What I meant was that when we were back in the days of in the middle of March, we had not anticipated that the lockdown would be so effective. I mean, maybe you had, but we certainly hadn't. We thought that this lockdown would reduce the reproductive number from 2.5 to maybe 1.2. And and if that was the case, we would have been happy, because then we would have a flatter curve. But we hadn't expected back then that it would actually cause the reproductive number to fall below 1. I was not saying that Denmark is special, just that it was rather a time. Yeah.
Okay. Can you comment on the contact structure? Give us a few hints on that.
Yes. As I said, the basic contact rates were taken from these British studies, the polymod here, and then with an extra PPC. Yes. And then we divided that into, these contacts here are divided between professional contacts and family contacts and the spare time contacts. And then we began fitting with the Danish statistics for how many people, for example, when we reopen certain workplaces, how many of these contacts are then re-established. So, so that was how it was done. And this model here, as I said, only operated in 2 age groups. So we integrated over the age groups to find the total number of contacts within, for example, what we call the young group, those below 60.
Okay, thank you. There are no other questions from the audience, so I suggest we switch. You become the chairman and I become the speaker.
Okay, yeah, okay. Well, thank you very much then. Thank you for excellent chairing. And now I will try to return the favor and introduce Professor Jean-Guy Caputo from the National Institute of Applied Sciences in Rouen in the French province of Normandy. Jean-Guy works mostly on partial differential equations, if I understand it, linear wave equations and diffusion equations and inverse problems.
Right.
And now you are here to tell us about, let me see, your title here is Epidemic Model on a Network Analysis and Applications to COVID-19. So I'm looking forward to hearing that. And with that, I pass the baton back to you.
Thank you very much, Uffe. So first of all, I'd like to thank the organizers, Matti and especially Danesh Patel and the University of Baroda for setting up this webinar. It is a very timely occasion, and if we have had the misfortune to be hit by the epidemic, and you are just in India, you're just feeling it. So maybe we can share some of our intuition about this. Uffe, is my screen visible?
Yeah, it's visible.
Excellent. So let me tell you about the talk. So this is more of an analysis talk. We started playing with a model, spatial model coupling SIR on a network. We started playing with this about 2 years ago with my colleague Arnaud Knipel, who does operations research in Rouen, and Fatima Mouatamid, who's a student. And we then the COVID-19 hit us, and we realized that we could apply this to it. And we're doing this with Bustamante Castañeda and Gustavo Cruz Pacheco. So Bustamante Castañeda is a student, and Cruz Pacheco is my colleague from Mexico. So the outline of the talk, I'll first run you through the data. Luckily for us, there's a lot of data available, and I encourage you to go on the websites and see what is going on in the other countries. So I'll tell you about this. Go through the model then. So basically it's SIR plus diffusion on a graph. And using this model, we can give some ideas on strategy of isolation. And we predicted the COVID-19 arrival in Mexico. And the model can also give us some ideas on the deconfinement. Okay, what to do when the deconfinement, the second wave that was talked about by Uffe, will it happen? Will it not happen? This kind of discussion. So this is the SIR model. Okay, I'm sure all of you are familiar with it. Just for to insist on it, flattening the curve, it's this green curve, the infected. When you reduce alpha, or if you reduce the contact, the R0, then what happens is that the infected curve goes down. You have less cases of infection. Okay. What's particularly interesting is that you can predict the peak of infection. This point here, which I call I star, and the value of S star at the maximum. Okay, as a function of I0, S0, the values at time 0. Okay, so now the data. Again, so the data comes from two main sources, the Johns Hopkins website and the Worldometer website. You see the number of confirmed cases, actually the death and recover, that for these early stages here it's the 1st of March. You see that it increases exponentially. Around the 15th of March, you see this break, and this break corresponds to the confinement starting, pretty much. Okay, you see the same in Italy. In Italy, it starts earlier, and the fit here with this green curve, this green line, is the exponential fitting. It's exponential 0.3 times the time. So clearly the lockdown is effective. Okay. So now when you look at the full data of the infected, when you look at the data of the infected for two countries, Germany and Italy, it fits pretty well with the SIR model. Okay, in green here, you have an SIR model. These are the parameters, 0.32, 0.18. This is adjusted with the population. We have a multiplicative factor on the number of cases, and this is the pretty much the adjustment parameter. But you see that the numbers match pretty well. So these countries, they behave well in a way. Okay, then you have other countries, and I go, and you have unexpected behavior. So Spain, for example, this is the situation for Spain. So you see, it looks like it's going to a maximum here, then another maximum, and then it starts going down, then it goes up again. Iran is even worse, actually. You see that it peaks, and then second wave coming up. So the understanding just using a simple SIR model clearly doesn't work for these countries. Okay, if you look at France on the regional data, this is the situation for France. The hospital admissions on April 5th to 2020, you see that there's huge clusters on the east here, huge cluster in Paris, 11,474 cases in Paris, and the rest of France is very quiet. These are the other regions of France. All the west is fairly quiet. You have the north and the Lyon area, which has some activity, and also Marseille and Nice, but all the west is quiet. So it's a very heterogeneous situation. Okay, if you look, so here's the data. The data comes from this website. These are data scientists who have compiled the data. And if there's a lesson maybe of the epidemic, is we need data or more data. It's very important to have this data. So by data I mean confirmed, recovered, and deaths, of course, but essentially confirmed and recovered to get an idea of the progression of the epidemic. So this is the situation in France. Again, the regional data. You see the in and out fluxes from the hospital every day. April 1st, April 15. So there's 4 regions presented: Paris, pink; the East, in green; and Rhône, in blue; and Normandy, where I live, in yellow. So first remark is that you have the East, which starts before everybody else. The East is clearly peaking before Paris. This is due to a super spreader event we had in Mulhouse. So the number of cases increased very rapidly in the East, and then it spread over to Paris and the rest of the regions. Okay. The confinement is starts here. Okay, so initially you see that these the initial values here are higher for the East than for Paris and Normandy. Normandy is very quiet. You see, there's a very weak peak happening. Okay, so. The motivation, this data is also a motivation for the model. And here's the model. This is so geographically you have a graph, okay, geographic graph. I'm showing you here the situation for Mexico, but these are the equations. So essentially SI model, okay, the recovered are not even in the model. We just work with S and I. And the additional ingredient is a mobility from one node to the other, okay? So let's say J is equal to 1. You see that 1 is coupled to 2, to 3, and to 5. So you have exchange of infected from 1 to 2, and 2 to 1, etc., from one to its neighbors through this term here. Okay, if you look, so the model was suggested by Brookman and Helbling in 2013 to model the influenza. It was suggested in a more complicated way. We really stripped it down to its bare bones. In particular, the probabilities were not symmetric, and there were other complicated things. Anyway, the model is well posed. It's positive. So there's nothing to worry about on the math side. You can reduce it to a graph Laplacian. So these are the equations. S is now the vector, S1, S2, Sn. And the same for I. And you couple the S and the I with this graph Laplacian matrix. The graph Laplacian, for those of you who don't know, it's a generalization of finite difference. If take the node 1, for example, the node to 3 other nodes, 2, 3, and 5. So I put 1 here for 2, 1 for 3, and 1 for 5, and so on. This is how you build the graph Laplacian. So the influence, let's first see what happens with this model. And a first thing to examine is what happens with the diffusion. So the same graph, the 6-node graph that I was talking about before, the left, the diffusion is small, is large, I'm sorry, and the right, the diffusion is small. Okay, and I start the outbreak at node 6. So this black guy here is node 6, and you see at after some time you have the peak at 5, then at 1 and 4, then at 3 and 2 finally. Okay, but everything sort of happens simultaneously. This is a situation when, for example, there's no confinement. Okay, people are free to roam, to go from one city to another, from one area of the city to another area of the city. And you see that the epidemic is synchronous over the whole network. Here on the right-hand side, there is some sort of distancing, or at least some time for the epidemic to travel. Okay, so it starts at 6, after some time it reaches 5, and then after some time it reaches 1 and 4, okay, simultaneously. 1 and 4 are the same distance, and then once it's here, it reaches 3 and 2. 2 is the last one to be reached because because 1 and 4 are in contact with 3. So this explains the advance for 3. Okay, and using this model, you can devise an epidemic criterion. Okay, the equations for the infected, the IDT, at the onset, you can reduce it to some matrix acting on I. And this matrix, what is it? It's just your graph Laplacian, your beta term, this is the identity, and you have your sources which will feed the epidemic. And there's an epidemic if one of the eigenvalues of this matrix sigma A is positive. Okay. Of course, this makes sense when there is a network, when epsilon is not too small. If epsilon is too small, then pretty much you can forget about the network and each node develops independently. So using this model, we can devise some strategy to isolate. I should rather talk about isolation rather than vaccination. So you start with a homogeneous vector of infected. Every city is infected with the same quantity. And what do we do to isolate? We kill the reaction term at a specific node j. So we set Sj to be equal to 0. And we compute the eigenvalue. Okay? So in the absence of eigenvalue, in the absence of vaccination, the largest eigenvalue is 2.5 10 to the minus 2. Okay. When you start vaccinating, what do you see? You see that the small number of links for a node, the vaccination is not very useful. Okay, for if you isolate node 6 degree, which has a one link, then you reduce your maximum eigenvalue by a factor of 2. It's not very useful. If your degree increases, you reduce it a little more. And if now you work with large degree nodes, then you reduce very significantly your sigma, your epidemic. So what to summarize this slide, no vaccination, you have degree an epidemic, a sigma 2.5 10 to the minus 2. If you isolate a small degree node, nothing really drastic happens. You still have the epidemic. If you isolate a high degree node, then you can pretty much kill the epidemic on the whole network. So, and we can make this argument, we can prove this using the Rayleigh type arguments. So this was the situation in December, and then the epidemic starts, and this is when we start working on the COVID-19. And what did we do? We predicted the arrival of the epidemic in Mexico. So the graph here is not a geographic, not a road graph like it was for Mexico. This is more an airline route graph. In red, you have Wuhan. The other nodes here are the other hubs of the airlines, typically Beijing, Shanghai, Japan, Western Europe, the Eastern USA, the Western USA, and Mexico, which is more isolated than the rest of the network. So these form a complete graph, the first 6, and Mexico is more connected to the United States than it is to the rest of the world. So that's what we described. So what do you see? You see that the epidemic starts here in Wuhan, and then it reaches the complete graph simultaneously. So it reaches nodes 2 to 7, these guys here, and then after some time it reaches Mexico, 8. Okay. So what happens in January is that Wuhan is isolated. So Wuhan is just connected to Shanghai and Beijing. And this is why we cut all the other links, and the epidemic goes from 1 to 2, the other hubs in China, to the complete graph, the rest of it, and reaches Mexico a little later. Okay, and using this, we were able to predict the arrival of the epidemic in Mexico around March 20th, up to a week interval, and this was correct. So now let me give you some hints on confinement. There's 2 ways to do confinement. You can reduce the contact rate at a node, or you can reduce, in this model, the diffusion, the travel between nodes. Okay. First, reducing the alpha. This is what happens here. So we're working with just one node, and we at this time, t equal 30, we increase the alpha from 0.3 to 0.5. And you see you have a little bump here. The number of infected is increased. There's nothing drastic happening here. Okay. If you increase the diffusion, then things can be pretty bad. This is increasing the diffusion, the left panel, increasing the diffusion at time equal 15, below the peak, before the peak. And you see that I'm working here with two nodes. Think of Paris, the big node, and Normandy, the small. I'm just plotting the infected. You see that the bump in infected in Normandy due to this increase in diffusion. Okay, if you deconfine after the peak, it's not as bad. Okay, you see that you prolong the infected, but you don't have such a big influx as before the peak. So these are my conclusions and some recommendations. We analyzed a model of epidemic, the essential ingredients, importation of infected, minimum number of parameters. We're working with data. We want to adjust the parameters to the data. So that's why we keep the number of parameters to a minimum. There's just 3 here: alpha, beta, and the diffusion. We generalize this epidemic criterion. We find that for large diffusion, it's best to isolate high degree nodes. This study and also our experience suggests that we should confine early, use masks as much as possible. You should control the borders. You want to avoid influx of infected. You want to avoid super spreading events. And you deconfine after the peak, and you deconfine slowly. So these are the papers that are, so there's a paper on the archive. This is the analysis, and this is the more medical-oriented article that appeared. So thank you for your attention.
Thank you very much. Let me see.
Okay. Let me stop the sharing. Pause, share, stop share. Okay.
Yeah, I think Professor Krüger, so you should be allowed, you should ask your question here.
Okay, I mean, thank you for the nice talk. What, according to your opinion, what are the high degree nodes for Europe now when we have borders open, either if you look at on the regional level or the country level? So you would say
let's say the regional level, the east of France, so Switzerland, Germany, the west of Germany, the east of France, those are the dangerous regions. There's a lot of traffic there. Yes. Mm-hmm. Mm-hmm. So I mean, if an effort was made, I would I mean, if some suggestion could be made, we want to take care of those regions there.
And how you would like, I mean, what you think are reasonable ways how to reduce these contacts in these high degree nodes?
Cancel super spreader. No, in Mulhouse, what happened in February 24 to 27, there was an evangelical reunion. This event caused most of the problems in the east of France.
Right, but this is on the node level. I mean, this is within the node, the super spreading.
This is, yes, yeah.
But I mean, I'm speaking about the reduction of the I mean, reducing the contact of the high degree nodes. This is a little bit more difficult, I think, to
maybe check the borders. Ask people, give questionnaires at the borders.
Mm-hmm, mm-hmm.
And be careful of clusters. I mean, these are the recommendations we were giving to the government of Mexico. Mm-hmm. You know, control the people coming in with cruise ships. Control the airports. You see, so
yeah.
This kind of thing. There are questionnaires. People have to cooperate. Huh?
Mm-hmm.
Can I ask, to which degree do you have you looked at this as high population areas, big cities, metropolitan areas as nodes, and then the surrounding suburbs, rural areas as, should we say, slaves? Is that a useful picture of understanding this here, that the epidemic spreads in cities that are connected, and then from there diffuses to neighboring regions with less population density?
You could say that, yes. Yeah, you can say that, because you see the capacity when I don't know if you recall the model. There's the Sj at node J is normalized by the capacity Nj of the node. So if we're talking a city like Paris or the region of Paris, we're talking 15, 20 million people. If we go to Normandy, we're talking 2 million, 3 million people tops. It's a factor of 10. Mm-hmm. So clearly there's we were very weary when they deconfined of the possibility of a lot of infected people from Paris coming to our region.
Thank you. There's a question here from the audience. If social parameters impact the model, that's how it's stated. So it's not entirely clear to me what the social parameters mean, but can you say something about that, social parameters in this model?
The model is very coarse-grained here. At this level, social parameters. There's no. We don't. We would have to go into more details, but at this level, there's no social parameters.
Thank you very much. With that, I think it is time for me to thank you once again, Jean-Guy, and then pass on the baton to our next moderator, who is Professor Will Childers.
Yeah, thank you very much for chairing this interesting meeting. And it's my pleasure to introduce the next speaker, and that's Robin Thompson. He's a junior research fellow in mathematical epidemiology at Christ Church, University of Oxford. His research involves using mathematical models to represent the epidemiologic and evolutionary behavior of infectious disease outbreaks. This includes using statistical methods to estimate the parameters associated with disease spread and pathogen evolution, and using the stochastic and deterministic models that he develops to generate forward projections. The main aims are not only to generate forecasts of specific outbreaks, but also to understand how disease is spread, so that forecasts can be made and control interventions can be planned with more precision. So happy to give the floor to Robin Thompson.
Thank you very much. Thanks very much for that introduction. Hopefully you can now see the slides okay. Does that all look okay?
That's fine.
Great, excellent. Yeah, so as you just heard, I'm based at the University of Oxford in the UK, and I work at Christ Church, one of the colleges in Oxford, but also in the Mathematical Institute. And I'm going to talk about some work that I did in the early stages of the COVID-19 pandemic. So in general, my overall program of research is about using mathematical models to answer questions at different stages of an infectious disease outbreak. And as an outbreak goes on, the kinds of questions that mathematics can be used to answer will change substantially. So in the very initial stage of an outbreak, the most important questions are questions like, are the initial cases going to lead on to spark a really large epidemic? Or are the initial cases going to fade out as just a minor outbreak? We're also interested in questions like, well, which interventions can we introduce to reduce the chance of having a large epidemic when there are just a small number of cases? And then in the middle phase of an outbreak, when you know you've got a major epidemic, the attention shifts again, and it shifts onto questions like how effective are current interventions and how can we minimize case numbers during the outbreak? But I'm also interested in the ends of epidemics, and this is something that perhaps is less well studied. Questions like how should interventions be lifted? And questions like, if we haven't seen any cases for the last 10 days, let's say, then does that mean that the outbreak's over? Or could the outbreak be persisting in individuals that aren't reporting disease? And again, mathematical modeling can be very useful to answer those questions too. So I'm going to focus mostly on those two initial stages now, the beginning of outbreaks and then the middle phase of infectious disease outbreaks too. So I'm going to start by talking about the very beginning of an outbreak and assessing the risk when you have a small number of cases that a major epidemic is going to follow. I'm going to talk about that generally in the context of infectious diseases, so not specifically about COVID-19. But then after that, I'm going to talk about an application of the underlying methodology to COVID-19, and in particular, an application that I did right back in January. And then after that, I'm going to go on and talk about how the kind of main mathematical modeling framework that I'm going to present can be extended to more complex models, so to include more complex features about disease spread through populations. And then after that, I'm going to change tack slightly. I'm going to talk about the middle phase of infectious disease epidemics, and again, work that we've been doing for COVID-19 about estimating disease transmissibility, specifically the reproduction number, or RT, and how that fluctuates through time. And then again, I'll talk about how the basic model for estimating the reproduction number can be adapted to include more detail in the models too. So that's the plan. So for the first half of the talk, the main question is, well, when a pathogen first arrives in a new host population and you see the first few cases, are those initial cases going to fade out, or are they going to lead on to a really large epidemic? And so this is an example. This isn't for COVID-19, this is for Ebola. So this is historical Ebola epidemics and the number of individuals that were infected in each of those historical outbreaks. And this is right up until the 2014 to 16 major epidemic in West Africa, the largest Ebola epidemic in history. This is all of the outbreaks of Ebola before that. And so what happens is, well, Ebola survives in animal populations, it comes into humans every few years. And when it comes into human populations, one of two things happens. Either you get a really large epidemic driven by sustained person-to-person transmission. So that was what happened in Uganda in the year 2000. You can see this outbreak here went on to cause 451 infections, so a relatively large outbreak. But then in the same country 4 years earlier, again, the Ebola virus came into human populations, but there was a very small outbreak. There was an outbreak in which there were only 2 infections. Those 2 infected individuals recovered or died without passing the virus on to anyone else. And so what you saw is just a minor outbreak rather than a major epidemic. And mathematical models can kind of mimic that behavior. So if you imagine running a stochastic simulation of a model like an SIR model, this is a stochastic simulation on the right, run using the Gillespie stochastic simulation algorithm. What I've done here is I've just run one epidemic, and if you do that once, then you might see an outbreak that looks like this. If you run another outbreak, you might instead see something that looks a little bit different. So it might look like the blue, but qualitatively, this is exactly the same. They're kind of the same outbreak, but just a very slightly different sequence of random numbers determining exactly when infections and recoveries occur and in which order. But if you run a third outbreak, so again, under absolutely identical conditions, then you might instead see an outbreak that looks like the red line here. The first infected host has recovered without transmitting to anyone else. And so instead you get this kind of minor outbreak with only 1 infection in it. And so what this shows is that by running these epidemics under identical conditions, just based on randomness, you can either see a really large epidemic like the blue and the black, or you can see a very small outbreak like the red. And that mimics what we saw on the previous slide for Ebola, where you could either have large epidemics or very small outbreaks. Okay, so this leads on quite naturally then to the idea that there's some sort of epidemic risk whenever you have cases arriving in a new population. So if you ran 1 million simulations of your mathematical model, of your simulation model, and they all look like the blue and the black, then you would conclude that the epidemic risk is 1. If you ran 1 million simulations of your epidemic model and they instead all look like the red, then you would conclude that the epidemic risk is 0. But most likely is that you run a large number of simulations and some of them look like the blue and the black. And the proportion that look like the blue and the black would be your epidemic risk. That's the probability of seeing a large epidemic starting from a small number of cases. But it turns out that we can actually approximate the probability of getting a major epidemic analytically. So we don't have to run a huge number of simulations of a stochastic epidemiological model. We can instead make an approximation. And this is how we do that. So we say, well, let's suppose that what we want to know is we want to know the major epidemic probability starting from just 1 infected individual. We then write down Q subscript I as the probability of not getting a major epidemic, starting from I infected individuals. So then Q1 will be the probability of not getting a major epidemic, starting from 1 infected individual. And then 1 minus Q1 would be the probability of a major epidemic, starting from 1 infected individual. So in other words, 1 minus Q1 is the quantity that we want to find out. So that's the probability of a major epidemic starting from an imported case. Okay, so if we have just 1 infected individual, there are 2 possibilities for what happens next. So we can write down the probability of no major epidemic starting from 1 infected individual as either that 1 infected individual infects someone else, and then we have 2 infected individuals, or that 1 infected individual recovers, and then we have no infected individuals. So in other words, starting from 1 infected host, we can condition on what happens next. Either an infection happens or a recovery happens. And then what we can say is well, what is the probability of no major epidemic starting from no infected individuals? Well, if there aren't any infected individuals, then there definitely isn't going to be a major epidemic. So Q0, the probability of no major epidemic starting from no infected individuals, is simply equal to 1. So Q0 is 1. And then Q2 is the probability of no major epidemic starting from 2 infected individuals. And if there are 2 infected individuals and you don't want a major epidemic, what you want is no major epidemic to follow from either of those infected hosts. And the probability of no major epidemic from the first infected host is Q1. And the probability of no major epidemic from the second infected host is also Q1. And so if those 2 infected individuals are independent, then Q2 is simply equal to no major epidemic from either. In other words, Q1 times by Q1. So in other words, you can approximate Q2 as Q1 squared. And so if we substitute those 2 things in, then we have this equation for Q1, and this is good because this is a quadratic which we can solve. And if we solve the quadratic, we get 2 solutions. And I'm going to focus on this solution here. So this solution here is simply 1 divided by the reproduction number of the pathogen. And so in other words, what we want is the probability of a major epidemic. That's 1 minus 1 divided by the reproduction number of the pathogen. So that's the thing we want. That's the probability of a major epidemic. Okay. And so in particular, this kind of work has been the basis for a number of papers that I've gone on to write. Broadly, what you see is this. You see that if you have a very transmissible pathogen, that's a pathogen with a high reproduction number, then the epidemic risk is very high. Whereas if you have a pathogen that's a lot less transmissible, then the epidemic risk is much, much lower. Okay, so that all kind of makes sense. So now I'm going to go, so that's some kind of general theory about how epidemic risks can be derived. What I'm now going to go on and do is talk about applying this right back at the beginning of the COVID-19 outbreak. And so the first that I knew of the COVID-19 outbreak was when I saw this thing in the top left. So this notice was posted on Twitter right back in January. I think it was something like January the 8th or January the 9th. And at that point, I was visiting one of my collaborators in Japan. And we saw this notice. And what this notice says is it says there have been a number of cases of atypical pneumonia that have been observed in the city of Wuhan. And the thing that those atypical pneumonia cases have in common is that they had all visited the Huanan seafood market, which is this market down in the bottom left. And of course, what happened next, we all know, which is that the numbers of cases started to increase. So in particular, by the 20th of January, we got up to 291 reported cases, most of which were in Hubei province, the province that Wuhan is a city in. But then only a couple of days later, so on the 22nd of January, we were up to 446 reported cases, including cases in different parts of China too. And the day after that, the first data from patients was released. So it's very incomplete data, but there was data from 70 different patients. And the question that I was asking at that point was, well, we know that we've got this really large epidemic that started in China. What is the risk of getting a major epidemic in countries outside of China? So for example, looking at the UK, what is the probability that we see a major epidemic of this coronavirus in the UK? And this relates back to the question that I was talking about a moment ago, specifically estimating epidemic probabilities. So this is what we did. So what you'll remember from the stuff that I presented a minute ago was that the epidemic probability depended on the reproduction number. So the reproduction number is, if someone gets infected, then it's how many people they're likely to go on and infect. And in particular, the reproduction number is the product of the rate at which an individual causes new infections, and then how long individuals are infectious for. And so this patient data provided very useful information on the second of these quantities, so the duration of infection. In particular, in the patient data, there was data for individual patients on the days that the individuals said that they developed symptoms, and then also the days on which the individuals reported to hospital. So this is one example. This is just for one patient. This patient developed symptoms on the 10th of January and then was hospitalized one day later on the 11th of January. What this means isn't that there was one day between symptoms and hospitalization. It actually means that the symptom onset to hospitalization period lies in some range between 0 and 2 days, because it could be the case that this individual developed symptoms at the very end of the 10th of January and then was hospitalized at the very beginning of the 11th of January, in which case that period would be basically 0 days. But it could also be the case that that individual developed symptoms right at the beginning of the 10th of January and was hospitalized right at the end of the 11th of January, in which case the symptom onset to hospitalization period would be 2 days. And so if we assume that the time between symptom onset and hospitalization is a period in which the individual could have been out there and spreading the virus in the community, which is what we believed at that point, then what that would tell us is that they were out there and spreading the virus in the community for between 0 and 2 days.
Robin?
Yes, hello.
There is Till Kruger wants to make a comment on the outbreak probability. Can you?
Sure, yes, please do.
Till? Till, please go ahead.
I have to mute. Sorry, my microphone was muted.
Oh,
okay. Just a small comment on this outbreak probability Q1, which you had at the beginning shown, right, as a function of R1. I mean, this SRR model, I mean, there's a huge literature on that topic, and mostly discussed in the context of random graphs, actually. And so if you go to the microscopic model corresponding to the classical SIR model, it's an Erdős-Rényi graph with exponential times in the infection times. And for that, you have this, since 50 years known, this outbreak probability is actually the outbreak probability of the associated branching process if you start with one infected. And the equation is a nonlinear equation. And what you have written down is the first order approximation if R1 is if the reproduction number is small, so close to 1. And then it comes precisely to the formula you have there. But you can generalize this very much, including really much more complicated structure. And then it's essentially a nonlinear integral equation, which has nice analytic properties to solve. You can read it maybe in the paper by Bolobash, Janssen, and Jordan from Cambridge. And the phase transition is given by the spectral norm of the associated transfer operator for the branching process, which describes the local outbreaks structure. I just wanted to comment that there is a big bunch on literature, and it's very well understood how to compute those things, even in much more complicated situations.
Yeah, absolutely. Yeah, that's really helpful. That's really helpful. And in fact, yeah, you're absolutely right that there've been a huge number of extensions to include lots of different things. So network structure being one thing, but also, as you said, the basic underlying assumption of the simple SIR model is to assume an exponential distributed infectious period. You can extend it in other directions too, so you can have gamma distributed infectious periods, and you can do all that analytically.
And the Poisson number of secondary cases. This is the second thing.
Absolutely, yeah, absolutely. Yes, you're absolutely right. This is a very well established kind of area of research for sure. So yeah, thanks. Okay. So just then to go back to then applying this to COVID-19. So we have this interval censored data. So we have data from lots of patients where we have intervals in which these individuals might be infectious. And so what we did then is we tried to estimate from this very limited patient data, we estimated the period between symptom onset and hospitalization and what that distribution looks like as a proxy for the infectious period. So in particular, we estimated a rate of removal, so a rate at which individuals go from being infectious to being removed. So in other words, a rate at which individuals go from being symptomatic to then being hospitalized and isolated. And what we did is we then used the very basic approach that I mentioned earlier in this talk to then estimate the probability if someone with similar characteristics to a patient in China came to another country, so came to the UK, for example, the probability that there is then a major epidemic in that country. And so what we found is that the central estimate based on the parameter estimation that I talked about on the previous slide, the central estimate is that there's about a 40% chance every time an imported case goes to a new location of seeing a large epidemic. But actually, based on the parameter uncertainty, that 40% chance could be anywhere between about 20% and about 60%. But the key result here, the key result wasn't the exact numbers. The key result is actually the figure on the right-hand side, which is that if you can reduce the period at which individuals that are infectious are out there and spreading the virus in the community, then you can achieve a very substantial reduction in the epidemic probability. So in other words, the key conclusion from our paper was, well, if we want to prevent or if we want to delay outbreaks in countries around the world, then really intense surveillance of imported cases is absolutely critical if we want to reduce the chance of having epidemics everywhere. So that was kind of the key message from this paper that I wrote right back in January when there was very limited information about coronavirus. And as we just heard a moment ago, you can then extend this in a number of different directions. So one direction that you can extend this in is to consider different types of infectious individual. So in particular, one thing you can consider is you can consider individuals that tend to report their disease very quickly and individuals that report their disease very slowly, right? It's not the case that everyone's equally likely to go and report the fact that they're infected after the same time interval. Instead, there are some individuals that are just naturally more inclined to go and report their disease very quickly and others that are likely to report their disease slowly. And so you can include that in the model too. I won't go into any detail about this, but broadly you use the same approximation that I talked about earlier. So you say, well, we'll write down Q, I, J for the probability of not getting a major epidemic, starting from I, fast reporters, and J, slow reporters. You write down equations for Q10 and Q01, so the probability of no major epidemic starting from a fast reporter or from a slow reporter. You condition on what happens next, and then you make the same approximation that I talked about before. So previously I said, well, Q2 is approximately Q1 squared. Now you can say that Q2 naught is approximately Q1 naught squared, and then make similar approximations throughout. And if you do that, what you obtain is you obtain two equations with two unknowns in this particular simplified case. And if you do that, you can solve those analytically again to obtain the probability of not getting a major epidemic, starting from a single imported case that's either a fast reporter or a slow reporter. And so we applied this again to data from Wuhan, and we saw broadly the similar results. So the main result again is this figure on the right, which says that there's a pretty substantial probability that an imported case will drive a large epidemic. But if you can reduce the period that individuals are out there and transmitting the virus in the population, well, then you can achieve a very substantial reduction in the epidemic probability. So again, the key thing here is to be really careful and to implement intense surveillance of imported cases if you want to have any chance of stopping outbreaks in countries worldwide. So that was what I was saying back in January. Some other work that I've done, so this is not specifically again for COVID-19, but an extension of the same idea is that you can extend it to any arbitrary number of groups. Again, like we heard earlier, there are a couple of different ways that you can do this. One way to do it though is exactly what I've just been talking about, which is you basically partition individuals into groups. You then write down an equation for Q1, 0, 0, 0, 0, 0, Q0, 1, 0, 0, 0, 0, 0, Q0, 0, 1, 0, 0, 0, 0, and so on. You then make the same approximations. You say that your Q2s look like Q1 squareds. You then write that down, and then what you end up with if you have M groups is you end up with M equations and M unknowns, which again you can solve to estimate the probability of a major epidemic starting from an imported case of a specific age. And so again, this is something that I've been looking at, not in the context of coronavirus, but more generally. Okay, so that's kind of the first part of the talk. So the key summary here is that we can use stochastic compartmental models to estimate epidemic risks. We can generate those analytically and we can adjust them in real time. And in particular, we can use epidemic data. So data like the line lists that became available from Wuhan in the early stage of the COVID-19 epidemic to generate epidemic probabilities. And we can extend that in a number of different ways to include additional model complexity. And I've just talked about a couple of examples just here.
Robin, you've got about 5-6 minutes left.
Okay, perfect. Yeah, no problem. Okay, so what I'm going to talk about now is I'm going to talk about estimating changes in disease transmissibility, specifically estimating reproduction numbers and how that varies throughout an outbreak. So the key question here that you might want to ask is, well, how effective are current interventions and which interventions are most likely to minimize case numbers? And so the central question, though, then is being able to estimate transmissibility when you put in new interventions. So in other words, given some case numbers, how has disease transmissibility changed, and therefore how effective are current interventions? The reason I want to talk about this briefly is that not only did we develop an underlying mathematical framework for doing this, but we also developed a software application just here. And this software application has been used in countries around the world for COVID-19. So there are two key quantities here. The first one is the reproduction number and how it changes through time. But the second key quantity, which is perhaps less well known, is the serial interval. So the serial interval is the time between successive cases in a chain of transmission. So in other words, what this serial interval distribution would be saying is that if I get infected, then if I go and infect someone else, then the chance that that infection is 1 day later is about 22%. The chance that that infection is 2 days later is about 35%. The chance that it's 3 days after I become a case in the data set is 20%, and so on, right? So that's what this distribution means. So what you can do is you can construct a very simple simulation model if you know the reproduction number and you know the serial interval distribution. So what you would do is you would say, well, to work out how many cases there were on this day, you would simply look at the number of cases the previous day, say that each one of those previous day cases will infect RT individuals on average, and that a proportion W1, so the serial interval after 1 day, will be cases that occur on day T. Similarly, you can look at cases from 2 days before, so from this day here, each of those individuals will infect on average RT infected individuals, and a proportion W2 of those cases will appear on day T. And you can basically sum back over all of the previous days to then get an expected number of cases on day T, given the cases that we've seen previously. And then what we can do is we can say, well, if we assume that there's a Poisson distributed number of cases on day T, we can then write down an expression for how many cases we're likely to see on day T, given the number of cases that we've seen previously and given the reproduction number. And the reason that that's useful is that what we actually want to know is we actually want to know the probability density function for the reproduction number, given the number of cases we saw on day T, right? We don't want to know the number of cases we see on day T because we know that, that's our data. We instead want to write down a probability density function for the reproduction number. And so simply, we've got the expression from the previous slide, and if we apply Bayes' rule, then we get a probability density function for the reproduction number, given the number of cases we saw on day T. Right? This is just the concept of a likelihood. And so this is okay. We can see data every day. We can see the number of cases we see every day, and then we can generate equivalent reproduction number estimates. And that's fine, but the problem with this is it generates estimates of the reproduction number that are very sensitive to randomness in the number of cases we see. The number of cases we see on a particular day is something that changes kind of randomly based on the number of contacts between individuals. It's not really a property of the reproduction number, it's just a random process. And so if we estimated the reproduction number in this way, we would see wildly fluctuating estimates of the reproduction number. And so the solution to this is instead to consider constant reproduction number estimates over time windows. So you assume that the reproduction number remains the same over a time window between day t minus tau and day t. And so if you do that, then you basically follow exactly the same procedure that I described a moment ago. You write down the probability of seeing the data given the reproduction number, and then use Bayes' rule to obtain the probability density function for the reproduction number given cases data from a period of length or a window of length tau days. And so if you do that, what you do is you take in number of cases per day, you make an assumption about the serial interval, you then make an assumption about the window length, so the length over which you're estimating the reproduction number, and then what you obtain is you obtain something like this, which shows you how the reproduction number is changing through time, where on any day your reproduction number estimate depends on the cases data from that day, but also from the tau previous days. That's what the reproduction number estimate is based on. We extended this in a number of different ways. One way that we extended this is to account for imported cases. So the idea here is that if you have a case that's imported to a new location, that case is a recipient case, it's not a recipient case from within your population. So they shouldn't be contributing to the estimate of the reproduction number. And so we extended this underlying basic framework to include that particular feature. If you assume that all of your imported cases contracted the virus locally, then you would massively overestimate the reproduction number. And so this is just an example very briefly to show that. So these are estimates of the reproduction number. This is actually for MERS in Saudi Arabia between 2014 and 2016. This is in the paper that we put together in Epidemics last year. So I won't go into too much detail about it, but the point is that if you assume that all cases arise from local transmission, you get very large reproduction number estimates that are the black. Whereas in reality, if you account for the fact that some of the individuals were imported cases from elsewhere, then you instead get reproduction number estimates that look like the red. And this can be important. This can be very important because something you're often wanting to find out is whether your reproduction number is above 1 or not. And you can see cases here where the black line is above 1 when the true estimate, the red line, is not. And then this is kind of the final thing. So what we've done so far is we came up with this framework for estimating the reproduction number given a time series of source cases and a time series of recipient cases. In the basic version of the model, you assume that the source cases, the vector of source cases is the same as the vector of recipient cases. When we account for importations, then we have imported cases that can act as infection sources, but those imported cases are not recipients from within the population. And so including that lowered the reproduction number estimates appropriately. And then going forwards, in theory, you could have time series for source cases and time series for recipient cases that are entirely independent of each other. So for example, if you have data on cases in healthcare workers and data in contacts of healthcare workers, then you could estimate a specific reproduction number estimate for healthcare workers. Similarly, you might have a different reproduction number for imported cases compared to individuals that contracted the virus locally. An imported case might be more likely to be aware of the fact that they may have been infected elsewhere, and as a result, they may have a slightly lower reproduction number than local cases do. And you can include that in this underlying framework too. So I'm going to stop there and just say finally, so parameter inference is very useful for estimating reproduction numbers in real time. This approach has been used, and in particular the software app and website that we developed has been used worldwide for COVID-19. But I think a really important open question going forward is, well, how different are reproduction numbers between different groups? What is the reproduction number in healthcare workers compared to in the rest of the community, for example? So I'm going to stop, say thanks very much for listening. Thanks to Danesh for setting this up and for the opportunity to give a talk. Thanks.
Okay, Robin, thanks very much for your very nice presentation. And there are some questions, I think, and Till is the first one to pose a question.
Yeah.
Till, please.
Thank you very much for the very nice talk. You mentioned at the very beginning that you had also done some study of how the things ends. And if you go for in the subcritical domain, so assuming you're subcritical, I mean, I found it a little bit surprising that there is very, very little in the mathematical literature on really extinction time in the subcritical case, even as just one paper on Erdős-Rényi models with exponential distributed serial intervals. But if you have more general distributions or more general graph structures, it's really almost nothing really on the mathematical literature known here. And differential equations model are somehow not giving you the right thing here because they have problems with small numbers and they don't get the stochasticity in and they go really down to zero. So I would be interested if you have anything to comment on this topic. I mean, yeah.
Yeah, sure. So, so I think you're absolutely right. I think you 100% have to be using the sort of stochastic analog of the differential equation models. That's definitely true because this randomness in when exactly extinction occurs is going to be really important. I think one of the key challenges with it. So I guess there are two distinct kind of sections of research. One section is the one that you alluded to, which is the sort of underlying mathematical theory and development of the underlying mathematics. I think that hasn't been developed very much at all, as you alluded to. The other side of things is the more sort of practical application side of things and applying it to data, in particular, even doing simulation studies. And I think that hasn't been looked at to a great degree either. Something that we did do for Ebola, though, is to look at when Ebola epidemics should be declared over. So the point there is, so what they do there at the moment, the World Health Organization guideline is that if you haven't seen a case in a country for the last 42 days, then you declare the epidemic to have finished. That's what their guideline rule is. That 42 days is based on twice the incubation period of the disease. So they basically say if you haven't seen a case for twice the incubation period of the disease, then it's very unlikely that there are cases still out there. The problem with that, though, is it doesn't account at all for the number of individuals that report disease, which again, so you have a kind of stochastic process, but then actually who goes on to report disease is sort of another level of complexity on top of that. I guess you could do it very simply by assuming that maybe some binomial sample of your infectious hosts report disease. That's one way that you can do it. Otherwise, you can set up a compartmental model in which you have non-reporters and you have reporters. And again, there's some probability when an individual becomes infected that they're a reporter or a not reporter. And you can run simulation studies using models like that. Essentially, you can run a simulation until you see no cases anymore. And then you can extend your simulation beyond that to look at, over lots of simulations, what is the probability that the epidemic is really over, given that you haven't seen any cases for the last however many days it's been in the data. That side of things has been developed a little bit more. So I wrote something on that last year, published in Philosophical Transactions of the Royal Society B. But that was really a very basic simulation-based framework. I think developing the underlying mathematics a bit more.
Robin, there are more questions. So.
Sure. Yeah, sorry. Yeah, that's it. I think more mathematical development is good too.
Yeah. In view of time, please, I'll try to answer a little bit shorter.
Okay, sounds good.
Jean-Guy Caputo has a question. So Jean-Guy, please, the floor is yours.
Hi, Robin.
Hi there.
My question is, I've been looking at the data for the UK. What is the situation there, and why did they stop reporting the recovered?
Yes, that's a very good question. So what is the situation there? I guess, so in fact, the graph that is exactly on the screen at the moment are reproduction number estimates for the UK. As you can see, they stop though right back at the end of May. The reason for this is just the fact that there's a reporting delay, as I guess you know. So the fact that there are delays between infections happening and then being reported, and then further delays between reporting and then appearing in the case notification data. So certainly, it appeared to be the case that the reproduction number was less than 1. It's currently unclear what the effect is going to be here of interventions being relaxed, because that's the situation we're in now. Everything's kind of beginning to be opened back up. In terms of why, in terms of the recovery data, that is a very good question. I don't know of any good data set, and in fact, it'd be something that'd be kind of useful. I don't know of any sensible data set for the UK on individuals being let out of hospital. The only thing I know about is the data that I presume you know about too, which is tested number of cases found through tests and deaths as well.
Okay.
So it's a good question. I don't have a good answer.
There's one final question by Uffe.
Okay, thank you. Thank you for the nice talk here. My question was about this role of the imported cases when you estimate the reproductive number. So is it my understanding correct that when a person enters from abroad, you assume that the entire infectious period takes place in the country that they're entering? Or do you actually have the day of entrance included in the analysis?
So in the current version of the analysis, what you said first is correct. And the reason for that is the assumption is that they came into the country when they were pre-symptomatic. And when we developed the underlying framework, the assumption was that symptoms and infectiousness coincided. Obviously for COVID-19, that may not be the case. And so that will be a very sensible extension of this work.
Okay, thank you.
Sure.
Hey, Robin, I think time is up. Thank you very much for your contribution to this webinar. And
Thanks very much. Thanks for the invitation.
Yes, and I think I hand over to the next chairman.
And that's going to be me, Matti. So Dr. Betty Nanyonga, are you around? And please open your microphone. Betty, can you hear us?
Yes, I can hear you, Prof.
Thank you. Thank you. Okay, so I have the pleasure to introducing next speaker, which is Dr. Betty Nanyonga from Uganda, from Makerere University. Uganda is a country of 40 million people, and Makerere University is a great university there. And Betty has been working on biomathematics, epidemiology, and many medical issues. And right now, she's also serving in the Uganda Scientific Advisory Committee on COVID-19. She has made major contributions also on the gender equality issues in Africa. So you're very welcome to talk here. And she also has a very timely topic, and she's talking about the misinformation spread. So information spread and misinformation spread. So welcome, Betty, and the floor is yours.
Thank you, Professor Matti, for the wonderful introduction. Like Professor Matti has said, I'm on the Scientific Advisory Committee for COVID-19 in Uganda, and what I'm presenting is one of our research papers. And we did this study because we found out that there was a lot of misinformation going around on social media in Uganda, and because of that misinformation, people were not really adhering to the mitigation measures that were being set up by the government. So we wanted to inform the public that if they continued with the misinformation, perhaps it might have repercussions in the number of the coronavirus disease cases in Uganda. So this is that was basically the objective for this research. But we have done a number of papers on mitigation measures, but I thought maybe I should present this on this forum. So I'm presenting this on behalf of the Uganda COVID-19 Scientific Advisory Committee. It is a team of about 20 people, and we try to advise on the ways to mitigate COVID-19 in the country. So briefly, the abstract was misinformation had shaped the perception during COVID-19 outbreak in the country. And many people in the country thought that it was a bioweapon, it was a hoax, and it heightened anxiety often produces fearful rumors. So there were lots of rumors going around on social media and online, mostly on treatment, local herbs used to treat coronavirus. We had people cutting trees, we had people self-medicating. So we thought that maybe we should try to inform the public and tell them how that it is very important for them to adhere to the Ministry of Health guidelines. So the major question we had was, how does misinformation affect the disease spread, specifically in Uganda, because we used Ugandan data to fit to the model that we use. So at the moment, as of June 18th, there are over 8 million confirmed cases in the world, over 440 confirmed deaths in 216 countries. But for Uganda, we have 732 confirmed cases, and at the moment, no death, but we have about 500 recoveries. But most of these cases are not Ugandan. They are not from Uganda. We have not had a community disease transmission. We have imports from the truck drivers at the borders and the Ugandans that cross to the neighboring Eastern African countries. And that is perhaps the reason why people are still skeptical that we actually have COVID-19 in the country. We have a few local transmissions, which were also a result from the people who returned in the country when countries were locking their borders. Those people who returned in Uganda and their contacts are the ones that brought the COVID in the country. And since they returned, the government closed all the borders, restricted movement. So there hasn't been a community transmission in the country. We've only had those people who returned, and then they border at border points. So we understood where these theories were coming from, but thought that perhaps we can inform the public. So the disease started, as coronavirus started in December 2019 in China, it continues to cause several global socioeconomic disruptions, including the largest global recession. Misinformation or rumors about the disease basically spreads online, and it leads to conspiracy theories regarding its origin, scale, and prevention, diagnosis, and treatment. In Uganda, we had a case where they thought that it was a bioweapon. The gods were not happy with the world, and we could use the local herb. We have a local herb to treat malaria. It went on social media that it was actually a cure for coronavirus. So with increasing concern about the pandemic, misinformation continued to spread from person to person, and this led to a relapse or a relapse in the mitigation measures. So currently, this is the COVID-19 status in Uganda, and we have here at the beginning is when we had those people who returned from abroad, and the country was locked on March 25th. All the people who had traveled were called and quarantined, and we had a small wave. The highest here was 11, and then it died off. On April 4th, we had a complete or total lockdown. So we didn't have any cases for about a month. And then they eased the restrictions on May 9th, sorry, and now we see a gradual rise in the number of cases. So even the cases that are Ugandans, are truck drivers who travel across the countries, within the communities, we have not had any transmissions, but we have epicenters only at the borders. So mostly, like I've mentioned before, the cases are imported. There is minimal or no local transmission, and this has caused unrest and conspiracy. Ugandans are skeptical about the cases. They are not certain that they actually exist. When they were easing the lockdown, we were advised to wear face masks in the public. Actually, the president advised that public face masks should be universal. But to date, when you walk within the cities, you will find that 1 or 2 people are actually wearing the masks. Others wear them to pass through the security checks, and then you will just see them hanging on their necks or on their foreheads. And this is a very big problem. And this is basically because they think that these cases are planted for the government, maybe to benefit economically from the donors or something. So this the research approach we used was we had a hypothesis that existence of the misinformation during the COVID-19 outbreak could facilitate its spread. We thought that if people didn't believe that we have COVID-19 in Uganda, if the lockdown was lifted, definitely people are not going to adhere to the mitigation measures. We are practicing face masking, we are social distancing. Everywhere you go in the open shops, there is water before you enter, and there is still restriction of movement because public transportation is still restricted, and even the private, you can't have more than 3 people in the car. But even with that, once they get out of the car, they forget about the mitigation. They only follow them to where they are going. So the question we had was, does contact between an ignorant and a misinformed individual, will it more likely cause an infection than a contact between 2 ignorant individuals? So an ignorant is someone who doesn't know the rumor or who does not believe in it. And a misinformed individual is one who initiates and then spreads the rumor. So this was our research question. We wanted to know the differences in the disease trend between these 2 groups of people. So analogies between spreading of coronavirus and dissemination of information are proposed to describe the growth and decay of the actual spreading process. So we assumed that the way the rumor spreads is similar to how a disease spreads. And mathematical models have been developed and successfully used to study the epidemiology of diseases since the early 20th century. And of recent, a new version was developed to clarify some aspects of rumor propagation. So for the disease, we have the standard SIR. And for rumor, we have ignorance, spreader, and the stifler. So the ignorant is the person who is at risk or who is susceptible to the rumor. The spreader is the initiator and the one who forwards it to other people. And then the stifler, these are the informed people about the dangers of this disease, and it includes the health personnel. So the mathematical techniques familiar in mathematical epidemiology are the ones we applied to analyze the infodemic. So the model used in this analysis is susceptible, infected, and removed for COVID-19. And each of these 3 compartments are subdivided into ignorant, spreader, and stifler, depending on the rumor status of the individual. So this is the model that we used. I've not included the R, but we have the susceptible, infected, and we had the level of the removed or recovered. And then for each of these, each of the susceptible and infected, we divide them based on whether they are ignorant. So this one is a susceptible ignorant, a susceptible spreader, and a susceptible stifler. This is an infected ignorant, infected spreader, and infected stifler. So we only have one model for one parameter for the rumor, which is lambda. That is the rate at which somebody starts spreading the rumor, and we assume that the rate at which they start spreading the rumor is equivalent to the rate at which they stop. People can freely stop spreading the rumor, or when they interact with the health personnel or with the doctors and they're informed of the dangers of the disease, then they can spread the rumor and recover. We assume that the informed, these people who are informed don't acquire the infection, but the people who are spreaders of the rumor, when they recover from the rumor, then they can go to IZ. So the stiflers cannot get coronavirus because they know how to protect, they know it exists, they know how to protect and prevent. But to get IZ, IY must recover. We also have a possibility of somebody who didn't have the rumor before they spread to get the rumor when they mix with the susceptible spreaders, but along the way they also have a chance to recover. Then gamma is recovery. So in the model, the innocent are defined as those individuals who are not misinforming people, but are at a risk of believing in misinformation in circulation and may act on it. And the spreaders are the misinformation initiators and propagators, while the stiflers are the informed individuals, including the Ministry of Health and public health officials. So while rumors and epidemics are popularly regarded as similar, it has long been known that there are important differences between mathematical models for them, and both can be subsumed under a general class of transient processes whose time-dependent evolution can be characterized exactly. So we started by determining the basic reproductive number, and this is a replacement number because it is time dependent, and it is similar to the Ebola outbreak that happened, the pandemic that happened in 2014. It has a similar structure as the Ebola because there is a paper that came out on rumor and Ebola, and this expression is similar to that. So we started by determining how the rumor spreads within the community. And you see that at the beginning, we have many people spreading the rumor, but as the disease grows, as it progresses, you can see that there is a lot of rumor going on in the population, but eventually it dies out when people engage with the stiflers, or people are informed, or when the government makes outreach activities to inform the public. So all the rumor happens midway through the disease spread. So we also constructed an infodemic curve, and so that for our case in Uganda, using our parameters, on day after about 2 months, we have the peak of the rumor. And when we get the peak, then it starts dying off. And this is when everyone has become aware of the rumor, the spread has become few, and the rumor has become general knowledge. Then it starts to die off, similar to the disease trend. Even for rumor, we have a similar trend that when it becomes general knowledge, the spreaders have no new people to spread it to, then the rumor starts dying out. So we wanted to find out at exactly what point does rumor become general knowledge. And you see that we have, I think it is day 50, and when about 50% of the population have heard of the rumor. So when 50% of the population have heard of the rumor, then it ceases to make new waves, and it will eventually die off. So we also simulated the effective replacement number. So this is basically effective reproductive number, so effective reproduction number for the rumor. And for the innocent, we see that initially they are not spreading the rumor, then they reach the peak and it eventually dies off. The spreaders will continue spreading until there is an intervention, or when the rumor becomes general spread, and you see that the stiflers eventually stop the rumor. So then we wanted to know if we have, how does the initial number of spreaders affect the disease outcome? We started by ratios. The first, this is 1 in 450. We wanted to know if 1 in 450 people spread the rumor, what would happen? Then we had 2 infected people in the community. When, as a result of these spreaders, when 2 in 450 spread the rumor, then you have 19 and so on. And we see that as the initial number of spreaders, those people who don't believe it exists, the people who don't follow the scientific guidelines or health guidelines, the more they are, the more likely that you'll have infected people in the community. So then we wanted to know how does the COVID progression rate and rumor progression rate determine, or how do they relate? How many people are you going to have when both of these parameters are increased? When the rumor progression rate is high, you have a high number of people who eventually get the infection. And if you try to control, if it is when you try to mitigate the rumor, when you try to control the further spread, depending on the efficacy of the control, you will see that eventually you have only 5 people. Initially, you have 5 people, and the number of people who eventually get the rumor are fewer than the other case. So from this, we concluded that if you initiate mitigation measures, if you try to stop the rumor, if you inform the public, inform them of the facts about the disease, how it is spread, how it is prevented, then people are likely to adhere, they are likely to comply to the health guidelines. So then we wanted to know when we attain a peak for different number of initial spreaders. And you see that as the number of initial spreaders increases, when you have no spreader, this is the epidemic curve, you will have a completely disease trend for COVID-19. And now these are proportions of Ugandans. So when nobody is spreading the rumor, then you'll have the initial trend of the disease. And on day 20, you'll only have 3 infected people. When you increase the number of spreaders, you'll have on day 30, you have 24 infected. This is the peak. So, and you see that the more people you have initially spreading the rumor, the higher the peak. So when you have 5 in 450, the peak is reached faster than the previous case, and you have a high number of people spreading the rumor and who are infected because perhaps they didn't adhere to the mitigation guidelines. So then we wanted to see the relationship between the cumulative number of cases, because we have the transmission probability that is a function of the cumulative number of cases. The higher the cumulative number of cases, the more likely people will listen to the health guidelines, and perhaps then the more likely you will have reduced number of contacts. So up to this curve was generated up to May 25th, and we wanted to know when we have 100% people spreading the rumor, what is the cumulative number of cases? So we tried to fit the rumor infected rumor spreaders data to cumulative to see if we can have a relationship between the two, and that is this curve. And from this we could tell that when you have this number of cases, you should expect this proportion of people spreading the rumor, or the other way around. So that is basically the presentation I have now. I'm sorry I've rushed it. I have a meeting that started at 2:30 Ugandan time. So I'm going to go through the recommendations, and then I'll be excused and exit this conference. So what we recommended was information surveillance should be included in the disease surveillance, and techniques used to search, profile, and understand rumor trends and appropriately respond to them. The dissemination of weekly COVID-19 situational report on all media platforms to ensure that the communities are fully informed about the status of the epidemic, and use of mobile applications for information would reach further where media platforms do not, and presidential and other addresses by relevant officials and experts should be conducted frequently to keep the population informed and grounded. Local councils and village health teams engage their communities about the dangers of spreading misinformation to disease outcome. So those are a few of the references, but I would like to thank you all for the opportunity to participate in this activity. Thank you very much.
So thank you very much, Betty, and I understand you have to rush to the meeting, so we will continue with our discussion unfortunately without you. But anyway, thanks for your talk.
Thank you, Professor Mati.
So now the floor is yours, dear participants. Anyone who has something to comment on Betty's talk, please, now it's the time. If there is no direct comments on this talk, then there is one question from Professor Kruger to actually all the panelists and the Indian participants. So are you there?
Yes, I'm here. This is a little bit related to this kind of rumors which spread around. I mean, as you said, one rumor, for instance, very prevalent here in Poland is that 50% of the population believes indeed, according to our studies, that the virus escaped from a biolab in China. But in India, I heard a strange comment from a colleague of mine from Kharagpur IIT, that many people in India are not afraid much of the coronavirus because there is a belief that India has so many diseases that, that they are somehow already immune against this kind of stuff. And I just would like to know what the Indian colleagues here on the panel think about this, if this is really just a private opinion of my colleague or whether this is indeed, according to your views, a common belief, which would be, of course, bad.
So are there Indian participants now in the panel? A comment from Professor Danesh, Dr. Shah. You are obviously the microphones are silent. So Danesh, can you comment on this question of Professor Kruger? Your microphone is mute. Your microphone is
okay. So can you hear me now?
Yes,
Basically, what happened that actually it is some kind of rumors also, but now people are much more aware in all rural areas as well as in urban areas. So they are taking much care of it, and they understand what exactly going on. So some kinds of rumors may be there, but exactly now people are much aware. That's what I would like to say. Kruger, are you?
Is there a social panel study going on in India about, I mean, how much people are afraid of the virus and things like that? Do you do some kind of stuff?
Yeah, I mean, people are afraid, but now they are settled properly. They are very settled. They understand the situation now, how dangerous it is. So people are taking much precautions about it, sir, according to me.
Mm-hmm.
Yeah.
all right. It's a pity that Betty had to go because I would have liked to ask her and also our panelists, what is your forecast for countries like Uganda, who seem to have very little reported cases, no deaths so far? Does this mean that these countries are simply so far behind the development in this epidemic? So, for instance, Jean-Guy Caputo, who you predicted the arrival of the epidemic to Mexico. What would you say about the African countries?
Matti, I would say she showed a very interesting graph. It showed that the situation starting from the lockdown, there were no cases or very few, and then they eased the lockdown. Some people came in from outside, and immediately it starts there. You see. So in order to predict the arrival, what did we do? We estimated the diffusion coefficient and estimated some connectivity. So to get to Uganda, what are the main connections? Uganda, let's try and remember, there's connections with maybe Belgium or some capitals in maybe England. I don't remember exactly what are the most connections. If you can estimate the number of connections, then you can say something about the arrival time.
Okay.
So it's not an exact science, Matti. Clearly.
Yeah. But your general opinion, what would be your best guess about a country like Uganda who have so little cases?
Well, if they manage to control their borders and prevent imported cases, then they're pretty good. They're doing well.
Okay.
Maybe just
the main ports of entry are the truck lines from neighboring countries, so that might be one for the virus to enter. Anyway, are there any other questions? If not, we maybe go forward.
Matti, maybe I would like to add a comment on Josephine's talk. I mean, on Betty's talk. Sorry, I think she's very right about the data issue and the information of the population. It's very important to have websites that give the data precisely, that even if there are some mistakes, but that clearly there is a will of the authorities to be transparent about that.
Yeah,
it's very important.
Yeah. This information and misinformation is also a common problem all over the world, and it was extremely important that Betty brought this up. Yeah. Okay, so I think now we are ready to pass on the task to actually Jean-Guy. You are the one.
So thank you, Matti. So the next talk is by Josephine Warimu Kagunda from Nairobi. So Josephine will tell us about predictive models of COVID-19 disease and the outcomes in Kenya. So please, you have the floor.
Thank you, Professor, so much for inviting me. Thank you, Professor Danesh, for putting me in the panel. I'm sorry, I had so many meetings. I'm in and out, but I'm here. And I would like to share something small, just a short presentation about the work that we are doing here. I'm sharing my screen. I hope you can see it.
Yes, we can see it.
Yeah, so I want to look at the importance of mathematical models, especially from this pandemic that has hit us very hard when we were not prepared. Somehow we thought it will not come to us because it was so far in China, but because of the air transport and the connection of business and social interaction between the world, the disease came, and we reported our first case in Kenya in March this year. So just a bit of introduction, the search for knowledge, and especially science intervention in cases where we have a disease that has a lot of uncertainties. The mathematical modeling, what is called as mathematical epidemiology, or the study of infectious diseases, has come in very handy to explain what the future would look like, and various inputs would give what kind of predictions, so that we can be able to help also the healthcare workers to prepare adequately. So we have been in a panel and ad hoc committees and consultation groups so that we can be able to understand the disease and then be able to put the understanding in mathematical language and in equations so that you can be able to do proper modeling and also give some report that can be able to guide the next steps. So the computation of the basic reproduction number, as we know, would help us to know how many cases are resulting from one primary case. And that would help us maybe to suggest the direction an infection trajectory is going to take. And that would help the government and the health ministry to increase the level of preparedness so that they are able to deal with the infection. Then they would also help us to identify the gaps in epidemiology, like when we are working, now we know what we are missing, so that when we are collecting data, we are guided and we are able to get targeted data for our models. Then we are concerned as modelers about how to determine a COVID-19 infection. Actually, we are having a problem in our country right now because there are so many asymptomatic cases, such that there are so many asymptomatic cases such that we are not able to really tell who is infected and who is not. And because of the deficiency examining who can you say is infected, example, typhoid, malaria, and other, for example, sanitation issues that have the kind of the same symptoms in COVID-19. Then we would like to identify the factors that are driving the infection locally, because the setting and context of our communities are slightly different from those ones in developing and developed world. And we would also want to predict the direction the trajectory will take in the near future. Maybe also to determine the time it will take and how much effort would help us stop new infections. And we would also like to measure which interventions makes how much difference. So finally, as modelers would like to find ways of communicating our results in a language that is understandable to all, so that we can be able to help our communities. So each model can have some kind of unique classes, or you can be able to cluster your population depending on your importance. And we say that we have critical computations that we can be able to do in our models. And one of the things that is of our concern now locally for the COVID-19 disease is the probability of infection. As I said before, because of the high number of asymptomatic cases and the weakness in contact tracing and the limited capacity of testing in the country, when we report our numbers every day, they're just probabilities, because we do not know actually how many people are out there. And so the models we are looking at the force of infection as a contribution of three groups: the asymptomatic people, or those ones who are suspect cases. Most of them are in quarantine centers, and majority of the people, because they do not know their status, they have not been tested, and also they do not know whether they are infected. They are out there in the population. So we have a problem of computing beta A. That is the contribution of the people who are asymptomatic, but they are spreading the disease. There has also been a lot of argument about the contribution of these asymptomatic people. There was a controversial paper that said they do not transmit the disease. And then the World Health Organization clarified and said, indeed, they do infect, and they have been estimated to contribute to up to 48% of all infections. So we'd also want to know and measure the contribution of the infected and symptomatic individuals. And we'd also like to look at the infection of the environment. there has been argument about the contaminated services. Maybe if you're traveling in public buses, are you able to pick the infection and how much of it? So in this, the environment, we are looking at the context of air. Air pollution in Africa and Kenya is a critical issue. And therefore, we would like to know how to compute this quantity here so that we are able to do the model. So this kind of force of infection, we have used it in several of the papers that we have done in malaria, typhoid, and HIV. And we would also like to maybe like estimate what value it would take in the new COVID-19 disease. So what we have seen in Kenya is the report that we have about the cases that we are cumulatively accounting for right now. We have a total of 4,044 cases. That was as per yesterday evening, the report that was given by the Ministry of Health. So we had 184 new cases, and that was the highest since we started doing the testing in the last 24 hours. Out of these 4,000 cases, we have male accounting for 2/3 of the population, that is about 2,778, while the female patients are 1,266. And then we have 107 people who have died. That was as at yesterday. Then we have the distribution of the disease in Kenya. As you can see, as you can see, we have most of the cases are actually around Nairobi. And this is where the first case was discovered because it came from outside. Somebody came from UK. And then the disease has since spread to Mombasa. This is our port where we receive a lot of our goods. And then the connection between the disease and this Lake Victoria region where we border Uganda and Tanzania is the border point where the truck drivers are transporting goods. So it is important for us to know that since the disease started spreading, the government put a lock. So there is no communication and people are not moving inter-counties. And then you can see that the other parts of the country are not really very much affected. There are a few cases, but they have kept now on spreading, which has been our concern. And then there has been the lockdown now of Nairobi. Within Nairobi, we have locked down some places. For example, Eastleigh was locked for 21 days. A hotspot, one of the informal low-income settlement where people live in flats and in very crowded houses, where people really come in buying, and it was closed off. So the infection in that town or residential area has drastically gone down because of that measure. Then we have the cumulative cases, which is now what is trending in Kenya. As you can see, the curve is rising steadily. And since the first case was discovered in March, up to until around May, the cases were still very, very low, below 1,000. And now between May and June, we have seen a steady rise and there is an exponential growth. So we are looking at a case where we do not know where we have reached the peak or not. But if things go as they are now, then it means that we expect this curve to steadily rise until something happens, then it comes down. So the projections are that maybe we have until September when the cases are going to start dropping, but we have to increase the testing capacity. We also have to increase the attitude, to increase the positive attitude of people. They agree to come out and be tested, because if they're not being tested, then it is not possible to know who has the disease and who doesn't. This is the case distribution by symptoms or presentation. The blue sector here is representing the people with the severe symptoms, and the orange part is representing people with no symptoms or with very mild symptoms, which is complicated the case in Kenya. So what the government has done now is because the out of 4,000, if you compute 88%, that was as at yesterday, then you have like more than 3,500 people are asymptomatic. And if we keep them in hospitals, then we will not be able to get space to take care of the people who have severe issues and comorbidities with other diseases, for example, diabetes, hypertension, cardiovascular issues, HIV, and cancer. So the government has started an initiative that is called the Home-Based Isolation Center, where patients are supposed to separate themselves or isolate themselves in their homes. And this one has been piloted. It is taking place right now. So they are releasing most of the patients who are asymptomatic. Then we have age distribution. As you can see, between 0 and about 29 years, we have very, very few cases. And then between 39 and about 49, we have less than 20% of the cases. Cases that is death. The blue bar is representing male fatalities, and the orange bar is representing female fatalities. So you can see that death, most of the deaths are occurring in the age between 60 years and above. And most of this old population usually have a lot of other complications. So it is not necessarily COVID deaths, but the COVID-19 has complicated their cases and making them more susceptible to the disease. So we have proposed a model that is we are calling side model. We have the susceptible population. We have the asymptomatic population who sometimes they are recovering before we have even discovered that they are sick, but they are infectious. Some of these symptomatic people, if they do not recover, maybe they can develop severe symptoms. So we call them I. And then the I can either die, and we have heard that the deaths are also contagious. They can contaminate the environment, or they can infect the people who are preparing for the burial ceremony. So the environment, as I explained, is representing the services, the air, maybe like the clothing. We have seen the doctors using personal protection, and if they are infected and they are misused, then they could pass on the virus to other people. So we are really thinking about the susceptible landscape in our country, because we can see, especially the Nairobi population, that we have majority of the cases are in Nairobi. And these are people who are young, because it is a working population with very few old people. And then we also have some cases in Mombasa, and the distribution is the same. So we would want to understand the susceptible landscape and this asymptomatic landscape. This is our key area of study, since the environment, we can be able to deal with it in another forum where they can be able to really measure the quantitative contribution of the environment to the infection. So in this model, we are assuming that the infected can also recover and go back to become susceptible, because from the hospital records that we have, they have been following up the cases. Those who have recovered, they have gone home. They have to come back to the hospital after every 14 days for retesting, and some of them have tested positive. So it means that we don't have any immunity, and if you are infected, you need to continue with isolation, wearing masks in public, and also washing your hands, social distancing and the like, because you are susceptible to get sick again. And then we have the rate of death. The rate of death for the infectious people, death can be modeled depending on whether the person has other diseases or not. And we can also structure that depending on the age of the person, because we have seen there is no death for the young people. Then we have, in the same model, we have structured our population depending on their age and also sex. So contained in two classes, we have the age class, that is A is for gender. So if you have I from 1 to 2 for that is for sex, you have J for gender, that is M and F, and then you have I for the ages, which are going to be structured depending on the distribution that we have seen before. We have 0 to 29 years. They have almost similar or homogeneous characteristics. And then we have between 30 and 50. And then we have between 50 and 60. And then we have 60 and above. Those are 4 classes. So I has 1 up to 4. And then because of the movement, we have seen that the disease is being transported by people. And as of yesterday, 40 out of the 47 counties in Kenya have the disease. So we have included migration of people between the counties. So this can represent maybe county 1 or town 1, and then this can represent county 2. So we have the model, which is compartmental, then it is age classified and age structured, and then it also has gender, and then it has movement. So I want to say that this is work in progress. So I may not be able to say much about that. So what else? So our susceptible population, as you have seen, a predisposition of other underlying issues, for example, vulnerability to those with the cancer, kidney disease, cardiovascular problems. We are also looking at genetics. Maybe are there some characteristic for Kenyans that make them more susceptible or less susceptible to this virus? We have also had arguments about other vaccines. For example, we have BCG, that is the TB vaccine that we are given when we are children. There is polio and also other vaccines. There is rumors, because it is not scientifically proven, that they are protecting people from developing severe disease. We do not know whether it is correct or not, so we are correcting data and doing analysis so that we know whether we can be able to maybe look at those patients who do not have symptoms. Do they have other vaccines that maybe are making it difficult for the virus to proliferate in their system? So we are also looking at socio-cultural characteristics of the disease, because 90% of the population in Nairobi, they live in low income, all very poor and informal settlements. So the kind of culture they live in is where one family lives with the whole of their members, maybe in 1 room or 2 rooms. We also have a hand-to-mouth economy, where somebody has to work for them to be able to feed. That makes it a bit different. Population, we want to know how many they are, and we also would like to know, are they infectious and what is the probability? And how long is that incubation period? Are we able to track and know when somebody became asymptomatic? That is working backwards, so that we know maybe how many people may have resorted from that particular case. And then we have the infected population. We have the death. We want to know whether the death that was actually caused by corona or not, and what percentage of that are dying from underlying issues. Can we say that the 104 patients that died actually died of corona? And what is the probability of infection from a dead person? We are still measuring those those parameters. And then we also want to think about the environment. How long does it survive? How long do the aerosols survive in the air? How long are they infectious? And what is the infection probability? And what does the quality of air tell us about the environmental infection for this disease? So the factors that are unique in our Kenyan context, as I have said, is the susceptibility landscape, the environmental, the healthcare capacity, and social cultural factors. So I would like to say that because we are still working on this, maybe in the next presentation, we would be able to present our results. But because the papers are being worked on, I would like to stop there. And thank you for giving me the opportunity.
thank you. Thank you for this interesting talk. Let me see if there are any questions on the. I don't see any questions. I have a few comments. Then, can you hear me?
Yes.
You can hear me. Great. You mentioned that most of the cases are in Nairobi and in Mombasa.
Yes.
Do you have any? I mean, Kenya is a big country, 52 million. Are those the main outbreaks, or there are others?
Actually, the first case was reported in Nairobi, and then there were cases that were discovered in Mombasa, especially in the port where they receive goods from ship. And so the main towns in Kenya are Mombasa and Nairobi. But you also have Kisumu. They move from Nairobi to Mombasa, Nairobi to Kisumu, and you can see the disease has traveled along that road.
Interesting. Okay. Is there a lockdown right now in Kenya?
Yes, there is lockdown. The schools are closed. The universities are closed. Nairobi, you cannot move. There is no movement between Nairobi and there is no movement out of Mombasa.
Okay. Okay. And maybe one last comment. It would be very interesting to predict the peak of the epidemic, because you are just starting right now, and using the population of the main cities, you can predict pretty much when it is going to peak. So that time will do you know this time more or less?
Yes, we have some results that are predicting what is going to happen if we have lockdown, if we have partial lockdown, if we have complete
so
lockdown.
when is it going to peak? When is it going to peak?
Let me show you just some graphs here.
No, it's just a question, a number, because that's what the politicians want to know.
Yes, they're speaking around October,
October.
September, October.
Oh, that's very far.
Continue with if we continue with the lockdown, if we open up, then it comes back to August, July, August.
Okay.
Yeah.
Right.
Yeah, we have some prediction, but of course the issue of the opening of the school, when we reopen the school, if you open all of them, if you open maybe half of the schools, if you open a quarter of the schools, maybe like the
Yeah, I'm surprised that at the
colleges, the upper primary,
yeah,
the high school scenarios.
I'm surprised that there's such a difference between the peak when you have the lockdown and the peak without lockdown. I was expecting more like a question of 1 month, but not 2 or 3 like you indicate. So.
Okay, the peak moves depending on the mitigation measures. If you open 80%, it goes to October. 67%, it goes to July, August. Then July, like that. If we open up right now, by next month we'll have a peak.
No, I know, but right now with the mitigation, just use the just use the data that you have at this time.
Yes.
And try to fit an SIR with that. Just a simple SIR. You don't need any fancy stuff. Just the simple SIR. You compute the coefficients, alpha, beta. This will give you a peak time. And that value is pretty robust. You see? The time at which it peaks, you can if you have enough data, you can have some ideas up to a week or 2 weeks, you know, but you won't be wrong by 2 months. That's my point.
Okay. Okay.
So I suggest that you do
that.
Yeah. Okay.
I still have a question.
Go ahead, Till.
If you compare the situation in Kenya with South Africa, if I'm looking at Worldometer, actually the time when they're starting is almost similar, but Kenya is much better doing. Do you think that's due to the better reaction of the health administrations, or where you see the difference, or is there what is special about South Africa?
I think it is the issue of the lockdown, because when the first case was discovered, they closed the borders.
Okay.
They closed the borders immediately. South Africa took longer. So people kept on coming in and going out. So the silent cases, that is our problem. Because when you come in and you have the disease for about 10, 14 days, really you can spread it to very many people. So when we closed the border, what remained was now the community transmission, which has now been our challenge because of the socio-cultural context of our society. People are careless, and people do not have the capacity of staying at home. They have to go out and look for food. That is what is driving the numbers right now. I would also like to say people got scared when they saw the numbers and the people who are dying in Europe. The people got scared, and for the first 1 month, people were able to stay in houses. Right now, people are tired and they are relaxing. They are going out. I think that is what is also driving that community transmission.
Mm-hmm. Thank you very much.
Welcome.
So, are there any more questions? Okay, so I suggest we thank the speaker. So thank you for the interesting talk, and I give the floor to Matti for the panel discussion if there's any time left. Matti, are you there?
Yes. Thank you, Zanki. And I would like to have a word from Danes. Is Danes around? Because we need to know from Danes how much time we have. I understand that the Vice Chancellor wanted to be around this time and say some final words. So let's plan how many minutes we can have discussion, and when the Vice Chancellor is available to have his final words. Danes, can you hear us? Well, Danes has muted his microphone, so let us discuss now some time until Danes tells us to stop. Are there some comments from the panelists now about this webinar so far? Some final comments from you guys who have been talking and commenting others.
Well, there was a lot of interesting information spreading over these last 2 days, but I have seen that many people in the public questionnaires ask for submitting the slides of our talks, and I'm just wanted to ask, what are the plans about that?
Thank you, Till, about that. I was also going to mention that, and this is again a challenge for Danes to respond to this request, And maybe Danes will communicate with the speakers and negotiate whether it's possible to make the slides available somehow. It has been asked in several comments from our audience.
Mati, hello.
Hello.
Hello. Yeah, Mati, I mean, our Honorable Vice Chancellor is going to join right now. Yeah, in a minute, he's going to join.
Okay, all right.
Okay, so he is joining.
If we have 1 minute time, so I will give my final words now. So I would like to leave to now all of us to think about what would be the next steps in this process that now this webinar started. Are there some ways of keeping in contact and possibly discussing about some international cooperation? So it's not necessary to discuss it too much today, but keep this in mind and communicate with Danesh, who is now the hotspot of this, this initiative, if there is some ways to organize some follow-up discussions, keep in contact and so forth. So other than that, I thank you all of
Mati, before you finalize, I mean, let Vice Chancellor would like to talk to us. Yeah.
Okay.
And then,
so
yeah.
Yeah.
Arun.
He's in.
Okay.
Namaskar. Am I audible, Professor Matti?
Yes.
Oh, so nice of you. And I'll just take 2-3 minutes just to, place on record my deep sense of gratitude. And I'm very happy to learn today from Professor Danesh that more than 42 countries participants. I believe it's a great academic opportunity that we could create for all the mathematicians of various parts of the world. And I would like to, appreciate the presence of Professor Dr. Uf from Denmark, moderator Professor Dr. Zin from France, Dr. Robin from UK, Dr. Betty from Uganda, and Professor Matti, who is with us coordinating this very important workshop on mathematics modeling right from its beginning yesterday. Dr. Josephine from the School of Mathematics, Kenya, and another moderator, Professor Dr. Jean. It was wonderful. I was listening to you very, very carefully because my video was off, but my audio was on. I'm really not very sure, but then I'm confident that these 2 days they were really very, very productive for research scholars, across the world, and the deliberations that took place, the expert views, sharing of experiences. Now, I'm not very sure, but then 2-3 thoughts which I have, which I would like to share, and then we would wind up. One is that, as you all know, that in these 2-day international webinar, we have 2 faculties, Faculty of Technology and Engineering, representing Department of Applied Mathematics, and then from Faculty of Science, we have Department of Statistics and Department of Mathematics. These are the 3 departments where they are carrying out teaching and research into mathematics. At the same time, we have set up what we call it as Institute of Interdisciplinary Studies, which I think in my opening remarks also I have highlighted that the need of the hour is interdisciplinary, because I think there is not a single area where I would say that you won't find the use and application of the mathematics as a discipline. It is so generic, it is so universal. So one important achievement according to me, because more than 5,000 participants or attendees in these 2 days webinar, they are with us. In fact, we have been able to reach out to a focus group, which I think is very difficult. Otherwise, because when we organize the conventional seminar or conference or symposium, maybe few hundreds or few thousands, but such a large, aggregation of mathematicians from more than 42 countries, I think that itself is commendable, and I think I owe it to all of you for your time and sharing of your experiences. What I want is that in near future, we would like to promote and strengthen the collaborations. Now that is very, very important, because I think if we want to grow collectively in terms of academic programs that we offer, as I told you yesterday, some of our departments, they try to collect live problems, and then they try to offer a solution to industry. That is what we are trying to do in our university. I also am of the opinion that you should help us in critically evaluating the quality of research which is being carried out at the Maharaja Sayajirao University of Baroda. You should help us by assessing the strength also of the various departments, and if possible, because we follow what we call it as choice-based credit system. So I think when there are certain modules which we offer, we do have international students, because that is also again incidentally being coordinated by Professor Dhanesh, who is the director of Office of International Affairs. So we do invite students, we take care of them, only they will have to bear what we call the to and fro travel expenses. Rest everything, we would be more than happy to have them here. We'll take care of them. At the same time, if they want to pass through the normal conventional formal process of evaluation, would conduct that evaluation, will transfer credit also to the parent university, the host institution. So these are the possibilities which I have in my mind. It is not just webinar. I believe we all should appreciate the support that we have received from Professor Matti and Professor Dhanesh Patel. I think they too deserve a lot of appreciation, because I think it is for the cause of academics. We really want to improve the quality of research. We want to improve the quality of teaching, and we want to expose these generation the new challenges that I think the whole profession is going to face in newer areas, because I don't think this kind of environment we have not faced now because of IT revolution and the way we use technology. I think collaborative research projects, collaborative teaching, in the department, because we invite experts across the world. So I do not know, Professor Dhanesh is the best person, or Professor Haribhai is with us here, Dean Faculty of Science. I'm not sure about, I believe all other heads of the department, they're also with us today in this webinar. I want that, it is not just that, we end up discussing, drawing certain recommendations. That's fine. I'm very happy about it. But I think we should take it to certain other level, where I believe we need to stand the number one above all our academic activities. I think this platform, we should build it further in terms of academic collaborations, research, and I believe some other innovative thoughts or ideas with the stalwart, because I believe the best brain of the mathematics, they were with us in this international webinar. So I express my deep sense of gratitude to all of you for a wonderful support to the Maharaja Sayajirao University of Baroda. And I'll tell you, though it is a state university, but we represent all characteristics of central university like IITs and IIMs. We enjoy academic autonomy. We can design the courses. In fact, I would request Professor Dhanesh, if you please take the support of maybe all the experts who are with us. I want them to guide us in designing of an online course, maybe of 30 hours, 2 credit course, where the conventional teaching in a lecture mode, some assignments, some other methodology for the evaluation can also be adopted. So these are a couple of my thoughts which I thought I wanted to share with all of you. I really do not want just that it remain with all of us just as an international webinar of 2 days. No, I think it is an opportunity for all of us to build long-term, rewarding, exciting, and continued association and interaction, so that we can create the interest of students in mathematics. Because if you want to change the world, if you want to make the world beautiful place to live in, I think mathematicians will have to play a very big role, and that is not possible without your support, your guidance, and your time. So I once again appreciate the presence of all of you here, and looking forward to have continued association with all of you. And my heartiest congratulations to Professor Dhanesh and his entire team, and Professor Matti and the other moderators of the various sessions for this wonderful opportunity that you all have collectively provided to the people across the world who love and who have passion for mathematics. I think that is the purpose. We are in education for that very reason, and I think we will have to ensure that we would keep on making the best of the contribution to this profession of teaching, learning, and research for improving the life of the people on this earth. I think with this word, I will sign off. I am very much here, eager to listen to reflections of any one of you, but I think I'm simply speechless, and I think this is the positive note that COVID has created an opportunity for all of us. It's not a challenge, but I think thanks to COVID, it has created an opportunity for all of us to be together. Otherwise, hosting an international conference in a state university, I think I know how much efforts we have to put in. So thanks to, I think, those people who have developed this technology, I think there also, we all know that mathematicians, people like you, contributed significantly. We want to see to it that we would keep this flag flying high and high in near future. I think that is from my side. Over to you, Professor Dhanesh. Dhanesh, unmute your mic.
Yeah.
Thank you. Thank you, respected Vice Chancellor. Thank you for. So now I think it's time to close our nice webinar. From my point of view, and yes, I think we agree that it was a great experience for all of us, and good for the humanity, I would say. As a final word, I was trying to share screen with you with a journal that Will Skilders wanted me to mention, and this is the journal Mathematics for Industry, but now I somehow messed
it is visible.
My screen so that I cannot.
Yeah, we can see.
Oh, so can you see it?
Yeah.
So this is a journal published by Springer in Europe, and they are now running.
We are seeing your email now.
We can see you. We see your email, but not the journal, Matti.
Yeah. I think you have to switch the screens.
I simply do not know what happened. So
you can open your browser.
It disappeared. I guess I now failed to do what I wanted. But you can look it up from Google, the Journal of Mathematics for Industry, and they are publishing a thematic issue about COVID-19. So anybody who is interested to submitting, they might find interesting information and possibility to submit articles. To summarize, thank you all about your contribution to this event, especially to Dhanesh, who made tremendous amount of work putting this up, and to all the speakers and all the moderators and all the participants around the world. So thank you and goodbye.